Osteoporosis in a 60-year-old female. Presentation by Juniper Voida for Nursing 601, Fall 2017. Mary Lou is a 60-year-old white female. She presents 6 weeks after an ORIF of a left intertrochanteric fracture. She tripped on a garden hose and fell on her patio steps. Her orthopedist referred her for management of her osteoporosis, which was diagnosed 2 years ago after a fractured wrist. Past medical history consists of hypertension, hyperlipidemia. She had menopause at age 52, left wrist fracture that was non-displaced 2 years ago. She has allergies to penicillin, sulfa, and lactose. Her current medications consist of calcium, 500 milligrams orally, twice a day, which was started after she broke her wrist, simvastatin, 20 milligrams, once a day, hydrochlorothiazide, 25 milligrams, once a day, and Tylenol, 500 milligrams, 3 times a day as needed. Social history: she's married, she has 3 children. She drinks 1 to 2 glasses of wine per day, 4 days a week. She also reports smoking about 10 cigarettes a week for 35 years. Her activity consists of light gardening and nothing else. Family history: her father died at age 67 of an MI. Her mother is still alive and well at 87 with hypertension, hyperlipidemia, and coronary artery disease. Her brother is 62 with depression, alcohol abuse, and pancreatic cancer. Her sister is 57 with hypertension and GERD. A range of symptoms review results in no fevers, chills, or weight changes. The patient denies headache, dizziness, vision changes. She denies chest pain, palpitations. She does report an occasional dry cough, which is likely associated with smoking. She reports no shortness of breath. She does report occasional constipation, but no melena, no dysuria, or frequency of urination. She does complain of aches and pain in her left hip, and to a lesser and more infrequent degree, her left wrist. She denies numbness, tingling, or any weakness. Our objective exam of Mary Lou comes back with vital signs within normal limits. Her temperature is 98.7, her heart rate is 87, respiratory 16, blood pressure is 139/90. She's 5'6", and she weighs 115, which makes her BMI 18.5, which is low, normal, but low. In general, she is a frail appearing female and no apparent distress. Her eyes, pupils are equal, round, reactive to light. She has no enlarged thyroid. She is alert and oriented ×3. She has fluent speech and a relaxed manner. Her skin is warm and dry. She does have some scarring over her left trochanter and her left wrist. Her cardiac rate and rhythm is regular. Her carotid pulses are 2+, there are no bruits. Her chest is clear to auscultation, no adventitious breath sounds. Her abdomen is soft, non-distended, non-tender, positive bowel sounds. She does have positive pulses on all extremities. She does not have any edema. She does have some tenderness in the left wrist and left trochanter, but she does have full range of motion in both of those joints. Mary Lou's lab workup will consist of labs to establish baselines and also to rule out any secondary causes, such as thyroid dysfunction or multiple myeloma. So we will look at a complete blood count, making sure that we don't see any anemia, which could be a sign of cancer or malignancy. We'll look at a complete metabolic panel. We do want to make sure that her creatinine is within normal limits. which hers is. We're going to look at her thyroid stimulating hormone. That thyroid dysfunction can be associated with a secondary cause of osteoporosis. Mary Lou's is within normal limits. We'll look at her calcium. Calcium can be low or normal in primary osteoporosis. Hers is on the low end of normal. We'll look at her magnesium. Again, it's the low end of normal. And her phosphorus is normal. All of these levels are appropriate for primary osteoporosis. We will look at a 25 hydroxy vitamin D level. Hers is 19, which is low. This does indicate that Mary Lou is slightly deficient in calcidiol, which is associated also with osteoporosis. We'll look at some liver function tests. Her ALT and AST can signify alcohol abuse. Mary Lou does report drinking 1 to 2 drinks per day, 4 times a week, but many patients do underestimate their alcohol use. In her case, her ALT and AST are within normal limits. We'll also look at her alkaline phosphatase. Hers is a bit high, but that can be because of her recent fracture. Those levels can stay high after a fracture for up to 3 months. So that also is in line with what we expect to see in Mary Lou. The next test that we'll look at is a DEXA scan. DEXA stands for Dual Energy X-ray Absorptiometry. This is one of the gold standards to assess bone mineral density. There is another, a quantitative computed tomography scan, or QCT, but that one is slightly more expensive. It exposes the patient to more radiation. It is slightly more precise as well. But we do have a DEXA score here for Mary Lou, a T-score of negative 2.5 for her spine and negative 2.1 for her hips. The negative 2.5 for her spine, as indicated on the tables to the right, do indicate presence of osteoporosis. It's right at the cutoff, but we can say that is a definitive diagnosis of osteoporosis in her spine. At the hips, it's negative 2.1, which is indicative of low bone mass, but not quite a diagnosis for osteoporosis. But we do have the number that is low enough to call this osteoporosis in the spine. If this was not an indicative of osteoporosis, there are a number of other tests that we could do, both serum and urinary tests that would look for other biomarkers of bone turnover. But based on her labs, we can call this diagnosis of primary osteoporosis. So we've diagnosed Mary Lou with osteoporosis. That is a skeletal disorder characterized by decreased bone strength and an increased risk of fractures. Typically, bone is continuously reabsorbed by osteoclasts and replaced with new bone made from osteoblasts. This process is known as remodeling. As we age, bone mass decreases, but the number of osteoclasts remains the same. This inequality, as well as physical activity, glucocorticoid use, decreasing sex hormones, and lipid oxidation, all lead to more bone being broken down than replaced, leading to decreased bone mass and brittle bones. Some of the risk factors for osteoporosis are alcohol use, corticosteroid use, low calcium, low estrogen, smoking, and a sedentary lifestyle. As we've seen, Mary Lou has a few of these risk factors. She does use alcohol. Excessive alcohol intake can interfere with the calcium balance. It increases parathyroid production and inhibits the enzymes that convert vitamin D to its active form. It can also result in hormonal deficiencies, which can lead to even lower estrogen in postmenopausal women. And alcohol use can also increase the tendency to fall, which can lead to fracture. Low calcium is also a risk factor for osteoporosis. Calcium is a vital component of bones, and it's necessary to keep them strong. Mary Lou is lactose intolerant, so her diet likely does not give her as much calcium as she needs. She is taking supplementation, which is good, but we will probably increase that supplementation to the maximum recommended daily allowance, since she's probably getting very little from her diet. Low estrogen is a primary cause of primary osteoporosis. This happens when women go through menopause and their estrogen production drops off. Smoking can also interfere with the remodeling process. Mary Lou's been a smoker for the last 35 years, so that is likely a contributing factor as well. And her sedentary lifestyle. Exercise is what gives bones something to work against. It creates density when they're exposed to resistance. So when a person is sedentary, they are not getting that force. Their bones are not being asked to work, and so they can become quite brittle. Our plan for Mary Lou treatment is based on a blend of therapeutic lifestyle changes, supplementation, and pharmacology. So starting with pharmacology, the guidelines recommend that pharmacological treatment be based on the following factors. The patient, if female, must be postmenopausal, which Mary Lou is. She must have a T-score of -2.5 or less at the femoral neck or spine. And we saw that Mary Lou does have a T-score of -2.5 at the spine. A hip or vertebral fracture. Mary Lou has recently sustained a left intertrochanteric fracture. And the final indicator is low bone mass plus a 10-year probability of a hip fracture of 3% or greater, as indicated by a risk assessment tool. This would be if our patient had not already had a hip fracture. So there are a number of different medications that can be used to treat osteoporosis. Bisphosphonates are considered first line. There are a few of them: alendronate, Fosamax, risendronate, Atelvia, zoledronic acid, reclassed, or ibendronate, which is Beniva. Of note, in 2016, the American Society for Bone and Mineral Research stated that after 5 years of oral therapy and 3 years of IV therapy for any of the bisphosphonates, a drug holiday should be taken due to increasing risk of atypical femoral fracture associated with use of the bisphosphonates. Another class of medications that are used are selective estrogen receptor modulators, or SERMs, which are raloxifene, Evista, or bazodoxifene. These will increase the levels of estrogen that are used by the body. And as I mentioned before, estrogen levels are associated with bone density. The higher the estrogen, the more bone remodeling and bone strength there is. There's a monoclonal antibody that can be used to treat osteoporosis, denosumab or Prolia. Calcitonin, which is a form of vitamin D, can be used. And recombinant parathyroid hormone can also be used. The medication is called teriparatide, or Forteo. This last class of medications are reserved for patients at very high risk. They have a very high cost and should be reserved for only those patients who have a high risk of fracture. I have selected Alolanfate for Mary Lou. As we can see on the left, she did say that, to quote, "I had a friend on Beniva and she broke her leg. They told her it might have been caused by the Beniva. Is there another kind of medication? I take calcium tablets, but I hate them because they are so big." So the alendronate is a bisphosphonate. Its mechanism of action is that it will slow bone reabsorption by inhibiting the osteoclasts and their precursors, which leads to an increase of bone mineral density. As you can recall, the osteoclasts are what break down the bone. The half-life is 10 years, as this medication is stored in the bones, and it can live there for up to 10 years. The bisphosphonates do have poor absorption. Their bioavailability is less than 5%. 20 to 80%, which is a wide range, is taken up by the bone, and the remainder is rapidly excreted through the kidneys. Because of this, one of the labs that we will need to look at is creatinine. If we'll recall, going back a couple of slides, Mary Lou's creatinine was within normal limits. Some side effects of this medicine are abdominal pain, acid reflux, nausea, constipation, diarrhea, flatulence, and photosensitivity. Adverse reactions are dysphagia, esophageal erosions, ulcers, osteonecrosis, mostly of the jaw, Stevens-Johnson syndrome, and hypocalcemia. Safety and monitoring. Like I said, the baseline creatinine to make sure that her kidney function is good and will handle the excretion rate. Bone mineral density, which we have established with a DEXA scan. Calcium levels, which are not low, they're within normal limits. Magnesium and phosphorus. Again, both of those were within normal limits. A starting dose will be 10 milligrams orally each day. Alternatively, this medication is available as a weekly dose. So if Mary Lou preferred, she could take 70 milligrams once a week. The cost is reasonable, 30 pills for $88 on goodrx.com. The teaching plan for Mary Lou regarding alendronate consists of education. She should avoid taking alendronate with food, as this will lead to the decreased absorption of the drug and also can lead to GI upset or reflux. She should wait at least 30 minutes after taking the medicine before eating or drinking anything besides water. She should take the alendronate at least 30 minutes before vitamin C and D supplements, as both of those can interfere with absorption. She should not discontinue supplementation with either the C or the D, as alendronate can lead to hypocalcemia, so she'll need that extra boost. Another important piece of education for Mary Lou is that she will need to take a drug holiday after 3 to 5 years of therapy to avoid any atypical femoral fractures or osteonecrosis of the jaw. So we will counsel her after 3 years to take about a year or 2 off from the medication. Drug interactions that alendronate can have are with NSAIDs and aspirin. They will both increase alendronate toxicity, so avoid using them and use Tylenol instead. PPIs and angiogenesis inhibitors can also increase the toxicity of alendronate. And then any kind of mineral salts like iron or magnesium, etc. These, as well as antacids, will decrease the absorption of alendronate, so avoid taking those concurrently. We will also tell Mary Lou that she should repeat her DEXA scan in 1 to 2 years. We want to continue monitoring her bone mineral density, and up to 1/6 of women who take this medication do continue to lose bone density. So we want to make sure that Mary Lou is not one of them. More teaching on therapeutic lifestyle changes for Mary Lou. We have a strong recommendation that she stops smoking. We can offer her smoking cessation support through medications such as Chantix, or an inhaler or a nicotine patch. We will also counsel her to begin 30 minutes of weight-bearing exercise 4 times per week. This can be in the form of weight training, biking, walking, anything that can increase her bone mass. We will counsel her to begin Pilates or yoga or Tai Chi 2 to 3 times a week to increase core strength and balance, which will be helpful in preventing future falls. We will increase Mary Lou's calcium supplements. She's currently taking 500 milligrams BID. We will increase that to 600 milligrams, which meets the recommended daily allowance for women 50 or older, which is 1,200 milligrams a day. We will also begin vitamin D3 supplementation at 800 units a day. The vitamin D3 is cholecalciferol, and that has been shown to increase the serum vitamin D, or the 25H vitamin D, more efficiently than the vitamin D2. So we'll recommend that Mary Lou take the vitamin D3 supplement. We'll also counsel her on some dietary means to increase both calcium and vitamin D. She is lactose intolerant, so she does not get any calcium from dairy products, which are a big source of dietary calcium. So we will counsel her to increase her intake of fortified orange juice, leafy greens, sardines, eggs, sunflower seeds, and we will also counsel her to decrease her alcohol intake and keep it to 1 glass of wine per day. That concludes this case study of Mary Lou. Here are the references that I used. Thank you very much.